You have done the research. You have toured the facility. You have read what you could find about the staff and the ratings and the inspections. And somewhere in the back of your mind, even after all of that, you have been operating on a quiet assumption that the people delivering direct care to your loved one have been properly screened, vetted, and cleared to work in a healthcare setting. That assumption is reasonable. It is also one that the federal government's own enforcement record shows nursing facilities frequently fail to satisfy, and that almost no family ever thinks to verify on their own. The federal government maintains a searchable public database of every healthcare worker, nurse, and nursing aide who has been formally banned from providing services to Medicare and Medicaid patients. Banned due to patient care violations, fraud convictions, controlled substance offenses, and state board disciplinary actions. The database is called the List of Excluded Individuals and Entities, maintained by the Office of Inspector General of the United States Department of Health and Human Services, headquartered in Washington, D.C. It is updated every single month, it is free, and nurses and nursing aides account for approximately 70% of all permissive exclusions in that database, the category driven overwhelmingly by state board disciplinary actions, the same workers who provide the most direct and intimate care to your loved one every day. By the end of this video, you will know the exact question to ask a facility administrator that will immediately reveal whether their screening protocol meets federal guidance or falls dangerously short of it. That one question takes 30 seconds. The answer tells you everything. In December of 2024, Sharp Healthcare, based in San Diego, California, paid $153,072 to settle an investigation by the HHS Office of Inspector General. The finding: Sharp had employed a nurse who had been formally excluded from federal healthcare programs. Not a background check failure in the traditional sense, a failure to cross-reference the specific federal exclusion database that exists precisely for this purpose. In the same month, American Healthcare Management Services, operating under the name Accura Healthcare and headquartered in West Des Moines, Iowa, paid $60,282 to settle an identical violation. 2 separate enforcement actions, 2 separate healthcare systems, 30 days apart. That is not an anomaly. That is a pattern. The payment prohibition attached to employing an excluded individual is total. If a nursing home employs someone on the exclusion list, Medicare and Medicaid cannot legally reimburse the facility for any services that individual touched. Not just direct care, administrative work, management functions, billing roles. Any contact with a federally reimbursed patient encounter becomes tainted. The potential repayment liability for a single excluded aide working full-time for 6 months in a 100-bed Medicaid-covered facility can reach into the tens of millions of dollars in clawback exposure. The penalties paid by Sharp Healthcare and Accura Healthcare were a fraction of that exposure. Facilities do the math. The Office of Inspector General's November 2024 compliance guidance for nursing facilities, published November 20th of that year, named exclusion screening as a priority compliance risk. The specific finding documented in that guidance: facilities routinely screen new hires at the point of employment and then stop. A nurse who is excluded mid-employment, after a state board action or a federal conviction, may continue working for months before anyone checks again. The federal guidance recommends monthly rescreening of every current employee. Most facilities do not do it monthly. Some do not do it at all after the initial hire date. What this data actually shows, when you look at it carefully, is not a series of isolated administrative failures. It is a compliance cost calculation. Monthly rescreening requires software, staff time, and process discipline. It costs money. The penalties for getting caught are a small fraction of the operational cost of doing it correctly. That is not a coincidence. That is a business model. The exclusion database itself covers 2 categories of banned individuals. Mandatory exclusions cover convictions for patient care violations, fraud in healthcare programs, and controlled substance felonies. These individuals must be removed from federal program participation. Permissive exclusions cover state board disciplinary actions, obstruction of investigations, and other conduct that gives the Secretary of Health and Human Services discretion to ban participation. Both categories appear in the same searchable database. Both categories are the facility's responsibility to screen against. And there is a separate parallel system at the state level, the Nursing Aid Registry maintained by each state's Department of Health, which flags aides found guilty of documented mistreatment, care standard violations, or misappropriation within that state's own administrative process. The two systems do not automatically cross-reference each other in real time. Independent research from healthcare compliance firms documents that, on average, a state exclusion takes 173 days to appear on the federal list. Some state exclusions take up to 2 years. A worker barred in the state registry may not yet appear in the federal database, and vice versa. If someone in your family is currently in a care facility or about to enter one, consider subscribing. This channel publishes investigations like this regularly, and the next one covers something that affects an even larger number of families than what we have covered today. I have looked at a lot of these OIG enforcement settlements, and the pattern that appears in nearly all of them is the one most administrators never volunteer. The violation is almost never discovered internally. It is discovered when a federal audit, a whistleblower complaint, or a routine inspection triggers a retroactive records check. The facility did not find the problem, the government found it for them. The deeper issue is structural. Nursing facilities operate under simultaneous pressure to minimize staffing costs, fill shifts on short notice, and maintain occupancy rates. When a shift needs to be covered and a worker is available, the incentive to rerun a compliance check on someone who is cleared at hire is low. The friction of rescreening is real. The probability of a random audit catching a specific excluded employee in a specific week is low. The math favors skipping the check. And the federal enforcement record shows that facilities, at scale, are responding to exactly that math. The part of this that most people miss is not the existence of the exclusion database itself. It is the gap between initial hire screening and ongoing monthly rescreening, because that gap is where the documented risk lives, and it is a gap the facility will not mention unless you ask about it directly. This brings us back to the database that started this entire conversation, the list of excluded individuals and entities, updated monthly by the Office of Inspector General in Washington, D.C., available at no cost, searchable by individual name and by facility legal name. Most families have never heard of it. Most facilities do not advertise that they are required to use it. Everything before this point is what the industry is counting on your family never knowing before you hand over care of someone you love. What follows is what they are genuinely afraid you will do with it. Here's how to verify the people caring for your loved one before you sign anything and how to keep checking after you do. First, search the federal exclusion database by the facility's legal name, not its marketing name. The facility's legal name appears on its Medicare certification documents, which you can request at any time, free. No time required. What it prevents: discovering after the fact that the entity itself is excluded from federal program participation, a rare but documented scenario that voids all Medicare and Medicaid reimbursement for services rendered. Second, ask the facility administrator this specific question. What is your exclusion screening protocol, and how often do you rescreen existing employees after initial hire? Federal compliance guidance recommends monthly rescreening of all current employees. If the administrator cannot answer this question specifically or tells you screening happens only at hire, you are looking at a facility that is not following current federal guidance. 30 seconds, no cost. What it prevents: unknowing enrollment in a facility with a documented compliance gap that federal auditors have already flagged as a priority risk. Third, search your state's nursing aid registry. maintained by your state's Department of Health, to check for any aide at the facility who has been flagged for documented mistreatment, care standard violations, or misappropriation within your state's own administrative system. Free, approximately 15 minutes. What it prevents. Relying solely on the federal database when the state-level disciplinary record may contain findings that, on average, take nearly 6 months to migrate to the federal list. Fourth, verify the license status of any registered nurse or licensed practical nurse providing direct care through your state's nurse license verification system, available through your state's Department of Health. Free, 10 minutes per caregiver checked. What it prevents. Facilities concealing a revoked or suspended license through a credentialing lapse that standard background checks do not always surface. Fifth, if you discover or suspect that an excluded individual is working at a federally reimbursed facility, report it to the Office of Inspector General's Fraud Hotline. This is the mandatory federal reporting channel for Medicare and Medicaid violations. No cost. What it protects. Your loved one and every other resident in that facility from continued care delivered by someone the federal government has already determined should not be there. The total time investment to complete all 5 of these steps is approximately 45 minutes. The average cost of a single adverse care event in a nursing home, measured in legal fees, medical intervention, and facility transfer costs, routinely exceeds $40,000. The database that could prevent it costs nothing and has been publicly available for decades. Before this video, you were someone the industry expected to rely entirely on the facility's own assurances about who they employ. You were someone who had no reason to know that a free federal database existed, that monthly rescreening is documented guidance that most facilities ignore, or that asking one specific question to an administrator would immediately reveal whether that facility is meeting the standard they are federally obligated to meet. You are not that person anymore. You now know the database exists. You know the question to ask. And you know that the gap between initial hire screening and ongoing rescreening is exactly where the federal government's own enforcement record shows the risk concentrates. If your family has been through this, or if something in what you just heard matched a situation you are currently navigating, share it in the comments, because you are not the only one, and your experience is evidence. Every video on this channel is built around one principle. Your family deserves to know how this system actually works before you are inside it. Subscribe so the next investigation reaches you in time to use it.